next speaker is Jennifer Kett. Jennifer is a physician in Pediatric and Palliative Care Complex at the Palliative Care Complex in Ridge Hospital in Tacoma. She works as a part of an interdisciplinary team to provide family-centered care for children with chronic life-limiting or life-threatening diseases. And I'm so thrilled that Jennifer was willing to come today because over the arc of our time together in the 8 conferences that we've done, this is the first time that we've actually really addressed the particular challenges that happen when children and youth are part of the landscape. And Jennifer's dedicated to fostering partnerships between the clinicians and the patients' families. And her current research focuses on improving family experiences in prenatal decision-making. She's going to help us understand some of the dynamics and challenges that arise when children and youth face serious illness or death, and help us understand how care needs to respond to the special needs of both patients and their families. Welcome, Jennifer.
Hi, thank you so much for having me. This is a really exciting day. Before we get started, I'm curious how many folks in the room are clinical, nurses, doctors, respiratory, okay, almost everybody. Anybody who's not clinical? We like you guys too. That's okay. All right, so I am here to talk today about pediatric palliative care. So if the theme of today's conference is treating the whole person, I'm going to talk to you about treating the whole person when they're an infant, child, or teen. These are the objectives that are in your program, but I think it's a little easier to talk about a roadmap for the talk. I'm going to just spend a couple of seconds on what palliative care is from my perspective, what's special about pediatric palliative care, what unique challenges we face, what our approach is, and who I think we need on the team. So what's palliative care? So this is your patient. You've just been informed by the lab that she has a really serious illness. What are the things, think for a minute about what's kind of starting to flood your mind. What kinds of things are you starting to think about? And usually when I do this in a small group session, the clinical staff start worrying about, what do I know about this diagnosis? What's the patient's prognosis? What's the plan? Where are we going to treat her? How are we going to treat her? Is there anything experimental that we should be thinking about? How am I going to tell the family this really difficult news? How am I going to tell them this bad news? That's pretty scary. And then what is the family's goals going to be? How are we going to incorporate those into what we do? Now just imagine for a minute that you're the patient and you've just found out that you have a serious illness. What are the things that start kind of flooding into your head? And most of us start to think things like, am I going to die? How is this going to affect my family? Will I be able to keep working? Will I stay in school? How will I afford this? Is God punishing me? Did I do something to make this happen? Am I going to be in pain? What's this going to be like? So I think of palliative care as sort of the bridge between those two very important perspectives that we see when we start talking about serious illness. And we'd like our bridge to always look like this, very charming and sturdy. Sometimes our bridge looks a little bit more like this. Sometimes we're doing this. But this is always where we're sort of trying to live. So what's special about pediatric palliative care? I think there's sort of 3 areas that we should look at. One is just some medical differences and challenges that we face in pediatrics. There's also some special legal and ethical issues in pediatrics that we don't often face in adult medicine. And then there's some social and some other challenges that I'll touch on. So first of all, in pediatrics, we take care of a huge range of ages. We take care of, let's see, it's hard to do. Infants in the NICU, premature infants. I also, and most other pediatric palliative care providers, take care of fetal patients, so pregnant women who know that they have a fetus with congenital anomalies. We can meet with them and make some plans about how to approach the delivery and the care after birth. We take care of school-age kids, adolescents, and even young adults. And my colleagues here from Seattle Children's Hospital, I think the concept of young adults there gets even stretched out even further, and some real adulty young adults. We also take care of kids with a wide range of developmental spectrums, so nonverbal infants, school-age children and their sort of concrete way of thinking about the world, adolescents and young adults who are a lot more able to embrace abstract concepts. And that's just the neurotypical children. I would say the majority of patients that we take care of in pediatric palliative care are non-neurotypical in some way. Another thing about pediatric palliative care is that our decisions may have long consequences. So when we're talking about those babies in the NICU who we're making tough decisions for, they may live 80, 90, 100 years, we hope, after some of those decisions are made. And that's a long time to live with potentially serious consequences of different sorts of approaches. Even our school-age kids with pediatric cancer, they have a hopefully long life to get through once their course of treatment is over, and may have secondary malignancies and other consequences. So we have to keep that in mind. I think the biggest challenge in pediatric palliative care is prognostication. This is just, it's always difficult in medicine, that concept of predicting what's going to happen and making the plan. But I think pediatrics raises special challenges. So this is a list of the top 10 leading causes of death for adults. I think it's from 2016 from the CDC. And at the very top of the list is heart disease. Cancer is a close second, and then many other disease processes. And I'll just take a quick look at heart disease. We know a lot about it in adult medicine. This is maybe old, forgive me, I'm a pediatrician if there's any like heart failure specialists in the room. But we know sort of the generally how heart failure progresses in adults, the different stages. We have different treatment approaches during those different stages. We can tell with some reasonable specificity when people are getting close to the end of their life suffering from heart failure. We know a lot about it. That's not to say that adults medicine providers never see rare conditions, patients who don't follow the expected trajectory, unusual circumstances. I mean, they certainly do. But we have a lot of data about a lot of adults with the same condition, and that really can help us sort of narrow our thinking in a good way as far as prognostication. In pediatrics, the top two, in pediatrics, in infant mortality, the top two causes of death are congenital malformations and low birth weight. That captures the majority of premature infants. That low birth weight category captures a lot of premature infants. Most premature infants don't die. But so this is for children under age 1. So we'll talk first about low birth weight infants. This is probably the category in pediatrics where we have the best data. So we take care of lots and lots of preterm infants. Most of them are enrolled in some way in a research study as far as gathering data about their outcome. So the National Institutes of Health has this fabulous, huge population study, and they have used that to help us figure out some key characteristics that we can use to prognosticate for preterm infants. So we put in their gestational age and their weight and how much oxygen they're needing and things like that. And the Neonatal Research Network calculator helps us make some predictions for those babies. And I made up some factors for a baby, but this is what it looks like. You can't see the numbers at the very bottom, but for this baby that I made up, it's predicting a 40% chance of death. But that's based on population data. When we look at how good we are at predicting for any one particular baby, the answer is pretty crummy. So a fabulous study by Bill Meadow and his colleagues basically had a team going around their very busy NICU with a basket of chocolate, and they would stop doctors and nurses and say, what do you think this baby's odds of survival are to NICU discharge? Are they gonna make it? And based on that data, they were trying to figure out how to predict which babies would die during the NICU stay and which babies would survive. And what they found is we're pretty bad at predicting. So this, here it is, this gray color is babies who died. And then these other colored bars are children who lived with varying degrees of developmental impairment. And so babies who were not predicted by anybody to die during their NICU stay, for the most part, survived the NICU stay. A few of them died, but most of them survived. But here's where it gets confusing. Babies who were predicted at some point by somebody in their NICU stay to die during that NICU stay about half of them died. The other half survived. Same with babies who more than one staff member on more than one day predicted that they would not survive their NICU course. About half of them died, the other half survived. Even for babies who 100% of the time when they asked a staff member, is this baby going to survive to NICU discharge? Yes or no. Even for babies who 100% of the time staff members said, this baby's not going to survive to NICU discharge, a little more than half of them died, but almost half of them lived beyond their NICU course, lived to be discharged. So what the authors concluded is basically that we are no better than a coin flip. That we could do no better than 50% in predicting whether sick, ventilated NICU patients would die in the NICU or survive to be discharged. So that's the disease process that we probably have the best prognostic information for in pediatrics, and still we're not doing so hot. I think I just want to touch briefly, I'm a neonatologist by training, and so I love this concept of neuroplasticity. That we were just talking a minute ago about, predictions of survival from the NICU course. Neuroprognostication is exponentially more difficult. Babies have a much greater ability than we do in this room to recover from and cope with neurologic impairments or neurologic injuries because of this concept of neuroplasticity, and premature babies even more than anybody else. For infant mortality, congenital malformations is the #1 cause. And that's true also for older children. So these are the mortality for children in younger school age and older school age. And again, congenital anomalies features pretty closely at the top of the lists. The very top of the list is unintentional injuries for school-age children. That's not so much a palliative care issue. And we'll come back to malignancies that we see in older school-age kids. So this concept of congenital anomalies is just a huge bucket. It encompasses thousands, if not tens of thousands, of different unique conditions. The CDC has a little graph where they sort of pulled 21, they're not even 21 of the most common, but 21 of their of the illnesses they were most interested in. And I'll just zoom in on the graph a little bit. Anencephaly, which is sort of at the top of the list alphabetically, that's a neurologic, severe neurologic malformation where babies are missing a substantial part of their cranium and the brain tissue either doesn't form or is actually destroyed in utero. This is not compatible usually with life beyond hours or days. And this is a condition we know a lot about that falls into that bucket of congenital anomalies. And still we're talking about 859 cases in the United States on average per year. So each individual provider or hospital is not seeing a lot of babies with this condition. And this is a condition that we know a lot about. So congenital anomalies encompasses this huge spectrum of rare illnesses, each of which may only have a few patients. This is just a webpage from the National Organization for Rare Diseases, which is a fabulous resource for both clinicians and also families about some of these rare illnesses. So those children with congenital anomalies, with rare diseases who go on to survive for some period of time, it is very hard to predict what their lifespan is going to be. And so this is a kind of common trajectory that's sort of displayed in pediatric palliative care, where we talk about the typical course. And what you see is that many kids with congenital anomalies or with genetic conditions or other kinds of medical complexity sort of do okay for a while and then have these crisis moments. And during these crisis periods where they're often admitted to the hospital or the intensive care unit, sometimes they recover back to their previous baseline, sometimes they don't. Sometimes they have these slower periods of decline in between. Sometimes they have periods of relative stability interspersed with these crisis moments. And what we talk about with parents is that it's very hard to know which of these crisis periods is going to be the terminal one. And so it's very hard to make plans when we're not sure if this is going to be a process that takes years and years or a process that takes months and months. It's just very tricky prognostication. Even pediatric malignancy, which essentially all of the children with pediatric cancer are enrolled in research studies. The number here you can see is pretty tiny. It's 2.2 in 100,000 children. The number of adults with malignancy is 158 or 59 in 100,000. So we have much, much, much more robust data on adults with malignancy than we do with children to help us kind of know where they're going to go. The last thing I'll say about prognostication is that children tend not to have comorbid conditions. So children with malignancies, for example, may have very healthy hearts, livers, lungs, kidneys, as opposed to adults with malignancy who may have heart disease on top of that or kidney disease or other things. And so kids can be pretty robust individuals. So even as we think they're approaching end of life, that strong heart and lungs may keep them surviving much beyond what anyone would have expected. So prognostication is the most difficult thing I think that we do in pediatric palliative care. I think it's our biggest challenge. But there's some legal and ethical challenges that I think are important to touch on. Most children can't make medical decisions for themselves, and they've never been able to do so. So in adult palliative care, I'm sure most of you are familiar with the idea that when a patient can't speak for themselves, we ask their surrogate decision maker, well, what did they want? You know, did mom have an advance directive? Did you talk to her about what she'd want in these circumstances? And if we do, then great. If we don't have that, then we ask the patient's surrogate decision maker, well, knowing your mom, what would she have wanted in this situation? That's called substitute judgment. And the surrogate may be able to tell you, well, you know, mom hated going to the doctor. She never would pick up her prescriptions. Even if we picked them up for her, she'd never take them. She really kind of wanted nothing to do with Western medicine. And based on that, we might infer that going to dialysis 3 times a week wouldn't be something that she'd be too excited about. But if we don't have either of those, then we're stuck with this concept of best interests. So we work with the surrogate decision maker to say, okay, we don't know what your mom would have wanted in this circumstance, but you know, which treatment option do we think maximizes benefits and minimizes risks? And that's the one we choose altogether. In pediatrics, we don't have the first two because children haven't generally been around long enough to be able to formulate these kinds of deeply held opinions about their health care. And so all we're left with is this concept of best interests. We're constantly doing these sort of risk-benefit analyses with parents. So children can't speak for themselves. Parents are generally the ones who are speaking for them, not in every circumstance. And most of the time, this works out great. Parents mostly are very interested in promoting their child's best interests. They are the most concerned and most interested person in what's going on with their child. And in the United States, parents are given very wide latitude in decision-making for children. So you don't have to send your kid to public school, you don't have to send your kid to private school, you don't have to homeschool your kid, you can choose between all those things. But parent decision-making is not unlimited either. And when the state feels like parents are not acting in their child's best interests, the state can intervene in the role of the parent. So you don't have to send your kid to private school or public school, you don't have to homeschool them, but you have to have them schooled in some way. You have to pick one of those options. And if not, the state is going to intervene for educational neglect. The same is true in medicine. Parents are given very wide latitude, but we're always paying attention as pediatric providers for times when the parent's decision puts the child at significant risk for serious harm. And if that's the case, then we ask the state to intervene. Adolescent autonomy is another tricky part of pediatric decision-making. So I said before, children haven't lived long enough to form a lot of opinions about their health care. That was a little bit of a lie. Most children actually do have pretty strong opinions about what should happen to them and what should happen to their bodies. And as they get older, as they get more developmentally mature, those opinions mature and along with them. And so finding ways to incorporate the voice of the child in medical decision-making, even as they don't have legal authority over their own medical decision-making, is a tricky part of pediatrics. So we may ask a 5-year-old, you know, which arm do you want your IV in? And they can give us that kind of information. But a 16 or 17-year-old who's going to enroll in an experimental trial for cancer treatment, they 100% need to be part of that conversation, just as any adult would. The tricky part, which doesn't happen often but can happen, is when the adolescent has one plan in mind and the parent, who's the legal decision maker, has a different plan. And those are tricky situations to negotiate. So in general, decision-making for children, parental authority sort of outweighs everything else most of the time. But we're always paying attention as pediatric providers for these moments when the parent's decision may put the child at risk of harm, or for these moments where we can sort of elevate the voice of the child in the discussion. So children can't speak for themselves, the decision-making is tricky, and we have to balance these legal, ethical, developmental, psychosocial, and family factors. And these are all also changing in real time. So that 9-year-old who you treated for cancer a couple of years ago, who's now come back with relapse at age 13, we're doing things very differently at that point. Some of the social or other challenges of pediatric palliative care. You know, children are not supposed to be seriously ill or die. Parents are not supposed to outlive their children. Other children are not supposed to lose a sibling, a classmate, or a friend. Grandparents are not supposed to attend their grandchild's funeral. There's a real unnaturalness to pediatric serious illness and grief that I think makes it very difficult at times. It can be isolating for families. While everybody may know, may have lost their grandparent or an elderly relative, that experience of losing a child is really a rare and unique one. And so I think parents can really feel isolated and sort of set apart. People don't know what to say to them. There's also, just like in adult palliative care, many losses often along the way. So there's the loss of that normal pregnancy you were expecting when you ended up delivering at 24 weeks. Or there's the loss of that child you expected to have when you find out that they have trisomy 13 or 18. There's the watching your child develop different deficits and lose abilities along the way, or not be able to participate in activities with their friends. And parents are pulled in many directions. It's very common in the NICU for the moms to feel guilty no matter what they're doing. So when they're in the NICU with their ill newborn, they feel guilty that they're not at home with their school-age children. When they're home with their school-age children, they feel like they should be in the NICU. They really have a lot going on. And then many parents feel this desire to sort of protect the child, protect them from information, protect them from hearing what's happening to them, protect them from hearing the word, cancer or tumor or whatever it is. We tend to work very hard to convince them that, first of all, the child probably already knows that something is happening and that what they're imagining is scarier than what the truth even is. But this is a real instinct that we face and have to work through with a lot of folks. I just saw this quote on the internet, and I think it sort of captures a bit of the unnaturalness about pediatric grief and loss. The hardest thing I've ever had to hear was that my child died. The hardest thing I'll ever have to do is live every day since that moment. I think we talk about pediatric grief in a way that's different from some of the other grief that we talk about. So that's some of the unique challenges we face. What's our approach? What are we doing? What do we do? So I said palliative care is a bridge. Pediatric palliative care, I think, is also a bridge. It's just a bridge that's kind of geared for children and their families. Just like in adult medicine, we help with communication, planning, relief of suffering. Just like in adult medicine, when we're talking about communication, we're assessing understanding. We're trying to find areas where the family is misinterpreting what the team has said. We're trying to coordinate care, not in the sense of calling to arrange all their appointments, but in the sense of cardiology said it's not the heart, and pulmonology said it's not the lungs, and ENT said it's not the ear, nose, or throat. And so the parents are sort of stuck with, okay, well, where do we go next, and what is it? And so I think the communication piece, the skills and the tools look very similar in adult and pediatric palliative care. This conversation could be going on between the palliative care physician and this could be the patient, this could be the patient's partner, this could be the mom of the patient or the grandmother of the patient or the patient's guardian. The conversation, communication, active listening skills are the same. But there's certainly some things that are really different in pediatrics. And engaging the child in a conversation about serious illness is sort of a special, unique skill. And I think most of us who do pediatric palliative care will never forget the first time that a school-age kid asked you if they were going to die. I mean, that's a hard moment. We do the same kinds of planning that you do in adult medicine, medical decision-making, advanced directives, preparing for the next phase of illness or treatment, hospice referral, legacy building. And many of these things look exactly the same. We are all dealing with that tension between length of life and quality of life all the time. Are we going to do one more round of chemo, or are we going to go home and be comfortable? It's the same. But some things look very different. Legacy building for a patient who died at age 85 with a whole host of children and grandchildren that they want to leave letters or videos for is very different from legacy building for a preterm baby who maybe only lived a few days in the NICU. And how can we help their family show that this baby left their stamp on the world? Relief of suffering, physical pain and symptoms, psychosocial suffering, spiritual suffering. These are the same in adult and pediatric palliative care. This concept of total pain, the physical, emotional, social, and spiritual dimensions of distress. And a lot of what we're doing is the same. Medication management. In pediatrics, we may use slightly different tools. We tend to use these FACES scales and other rating scales for pain assessment. So a lot is the same, but there's some things that are different. I think the hardest thing for teenagers going through serious illness is being isolated from their peer group, being disconnected, being different, and that really, those discussions have sort of a different flavor to them than a discussion with an adult. So pediatric palliative care is geared towards pediatric medicine, but in a lot of ways, the sort of foundational skills are the same as they are in adult medicine. All right, we're almost at the end. And then you get a break. Who do we need on the team? Oops. So in 2013, Chris Feudner from Children's Hospital Philadelphia did a study about pediatric palliative care programs. And what he found that there was this sort of explosion in the mid to late 2005 to 2010 of pediatric palliative care programs being developed. And so when he asked children's hospitals, do you have a pediatric palliative care program? 70% of them at that time said yes, and I think the number is even higher now. The AAP has come out with guidelines recommending that all large healthcare organizations serving children with life-threatening conditions have dedicated interdisciplinary pediatric palliative care and pediatric hospice teams. So this is very helpful, our big national organization supporting the importance of this work. Cannot figure out where to point this guy. So who do we need on our team? There's more programs, but who's doing it? Who's in the program? This I stole from a lovely hospice website, and as most of you I'm sure know, the folks on a hospice team are mandated by the government. So you've got to have a medical director, you've got to have nurses, you've got to have a social worker, you've got to have a chaplain, you've got to have volunteers. Most hospices include some kind of complementary and alternative medicine practitioners or music therapists or Reiki or things like that. So hospice has it figured out as far as who you need on the team. In pediatric palliative care, that's the kind of team we'd like to have, but most of us don't have yet. This is also from that Feudner study, and what he asked was basically how much FTE do you have for each type of practitioner on your peds palliative team. And the way he looks at it is a little bit confusing. It's percentage of programs with 0 FTE for any particular category. So, right? Wow. So the percentage of programs with 0 physician FTE was 40%. The percentage of programs with no nurses was more than a third. As we hop down the list, no social worker, 2/3 of programs. No chaplain, 75% of programs. No child life specialist, 80% of programs. And as we keep going down, psychologist, pharmacist, some of the other people we'd really want on the team, almost no programs had anybody, any kind of FTE. That doesn't mean they can't access them. So where I am, in about a month or two, I will be the whole team. But I can still access the child life specialists in the hospital, social workers, pharmacists, and things. But that's different from them really being part of the focus mission. I go up to Seattle Children's sometimes for their morning meetings, and there's like a whole conference room filled with their team, and I get super jealous. And they bring food, and it's wonderful. But the reason is funding. On average, peds palliative care programs cover about 10% of their revenue through billing, and the rest is really covered through philanthropy or hospital operations budget. So in this climate, in this changing healthcare universe right now, that is a really vulnerable position to be in. Not only to not be a revenue generating service, but to be a service who can't even make your own ends meet is pretty scary. The good news is there's lots of agencies working on this problem. The AAP has a really active section on hospice and palliative medicine. The National Hospice and Palliative Care Organization has started to make pediatrics kind of a bigger part of what they've been doing. The Center to Advance the Center to Advance Palliative Care has also started to focus on how to develop and then help sustain pediatric palliative care programs. And then, of course, this fabulous organization that we're all here for today. So there's more and more growing body of support for pediatric palliative care, but there's still quite a bit of work to be done. So thank you.